listening 20 some odd. It usually will double shortly. Joshua Milner, who's the head of allergy at Columbia University in New York City, is our speaker this morning on, I think, the general topic of mast cell disorders and mast cell mimics. An important, interesting topic in our area. So thanks for joining us, and go right ahead. Put your slides up. So far, I just see you.
Yes, well, no one wants that too much of that. So I will share my slides. Hopefully, oopsies, I wasn't at the beginning, I guess. Okay. So thanks so much for the chance to talk out west. Actually, I do appreciate the fact that it's 10 o'clock here and not 7 o'clock in the morning. So more power to you guys for being on. I have no conflict of interest for this particular talk. So what I'd like to do is give an overview of mast cell activation syndromes, then spend a little bit more time in detail on the idiopathic mast cell activation syndrome, and a few points regarding mastocytosis, and then finish with, oopsies, for some reason it's automatically forwarding here, I apologize. A few moments on hereditary alpha tryptasemia as well, and in general, what to do with tryptase elevations or lack thereof. So first of all, for the overview on mast cell activation syndromes, there are any number of definitions and criteria that are out there. There are generally agreed upon consensus criteria that are sliced and diced in different directions, depending on the journal that you're reading and the such. But for the broad topic of mast cell activation syndrome, there are three criteria that have been created to sort of at least help define what it is, even though, as we can discuss, it's not at all going to be inclusive of disorders that are impacted by mast cell activation. But just so that everyone knows what we're talking about when we say the mast cell activation syndrome, there are criteria A is to have severe and recurrent systemic mast cell activation syndromes, okay, involving at least 2 organ systems for it to be systemic. And severe and recurrent, I guess, in some ways is often in the eye of the beholder. Criteria B, which is really the trickiest one and is least met, mostly because of technical issues, not necessarily because because it isn't done, not necessarily because it doesn't exist. And that is to have the involvement of mast cells documented in some way. And the main marker, the most validated marker, is an increase in the tryptase level from a baseline level to when the patient actually has one of these symptomatic episodes. So an elevated serum tryptase in someone who walks in and says, a week ago, I had a terrible episode of flushing, in no way is diagnostic of a mast cell activation syndrome at all. It has to be the comparison of the baseline versus when they're symptomatic. And we can get into this a little bit more, but the idea is that it's a 20% increase over the baseline plus an additional 2 nanograms per ml. So if someone's baseline tryptase were 10, they would have to have a tryptase over 14 when symptomatic to meet criteria B. Overwhelmingly, this is not met usually because wherever they are during the acute event, a tryptase is not drawn. It's that simple. ERs won't do it, urgent cares won't do it for any number of reasons, including they don't want to have to follow up on the result, which will take days to come back. And then the third criteria is that when these symptoms happen, or to prevent these symptoms, a mast cell stabilizing agent or mediator blockade works. So that criteria is very often met. Of course, it's almost always subjective. The response to the whatever antihistamine or mast cell stabilizing agent are provided. But to be clear, Criteria A and C are often met, excuse me, and I apologize that the clock on my thing just keeps advancing, so I'll have to go back every now and then. But criteria A and C are met very often. They'll walk in and say, I had these terrible episodes, and when I take antihistamines, I do better. If I go off my antihistamine, the episodes are going to get worse. But rarely will you actually have a documented elevation in that tryptase that meets criteria B. Now, having described what the mast cell activation syndrome is, it's often eye-opening to realize there are three different mast cell activation syndromes. The first is primary MCAS or clonal MCAS, and that's sort of the classic symptomatic mastocytosis. That's what it is. Symptomatic mastocytosis is considered a primary mast cell activation syndrome. Then a secondary mast cell activation syndrome would be, well, a good old-fashioned IgE-mediated allergy. So someone has recurrent anaphylaxis to peanut, because every time they have a peanut, they have anaphylaxis. That meets the criteria of a mast cell activation syndrome, but it's a secondary mast cell activation syndrome to the allergy. It doesn't mean that there's any other magical thing going on, that this person anaphylaxis every time they eat something that they're allergic to. That's just food allergy. There's nothing more to be said about that in and of itself. The one that makes it into the press and makes it into the patient's complaint or concern, or makes it onto any number of websites or questionable literature that's out there, is idiopathic MCAS, which is where you have met criteria A, B, and C, but there really isn't an IgE-mediated explanation for it, and there is no evidence of clonal mast cell disorder like mastocytosis. This alone is head spinning to patients very often when they come in. It also is either dismissed out of hand by clinicians usually, or it's assumed that the patient is out of their mind by a clinician if there's no evidence of IgE mediated allergy or mastocytosis, or it is over diagnosed. And so again, usually criteria B is just assumed because you can't get it, but we assume it's going to be the idiopathic mast cell activation syndrome if criteria A and C are met. Very often, my answer is, does it even matter? If the mast cell blockade helps you, for the most part, that's it. If it doesn't help you and you still have symptoms that look like mast cell mediator release to the clinician, there isn't much more to be doing except perhaps Xolair. And if the patient happens to meet a criteria for which Xolair could be given, that can help. And we'll discuss that further. Does it really matter if they have the diagnosis or not, for reasons we'll discuss? Okay, this is just in terms of working up mast cell activation syndromes. So again, the assumption is that you've met the criteria, which again is a very difficult assumption to make. At that point in time, you get referred to a reference center for mastocytosis, mast cell diseases. This is rarely the case. The patient is either referred without this particular criteria of the elevation in a mediator, or they have already been, so they've already been referred, or they're plastered with a diagnosis of some sort, or the mastocytosis or mast cell disease person is self-referred by the patient because they don't want to go through the gatekeeper of an outside allergist because of how much difficulty they've had. That's just how it is often in the real world. Then the severity is assessed, and the question is then worked up: is it secondary or idiopathic MCAS? Really, one of the best ways to help in that is to look for whole blood for KIT Th16V. The digital droplet PCR is sort of the most sensitive way to detect that. If it ends up being positive, then you're off to the races. Then bone marrow biopsies can be performed, and then the disease can be staged and the such. And then, of course, if there are other symptoms that are going on, like splenomegaly or lymphadenopathy or the such, further workup is done to see if actually there's now a myeloid neoplasm in addition to the typical mastocytosis. Okay. Now, a lot of attention needs to be paid to tryptase, because right now that is the most well-accepted mediator to be elevated. Tryptase is made in monomers and then gets packaged into tetramers, in the granules of a mast cell. And when you degranulate a mast cell, it's these tetramers that are then released, certainly during IgE-mediated reactions. They can be released in certain myeloid diseases, like mastocytosis, or in certain genetic disorders where the mast cell compartment is affected, like a disorder we described, PLAD, where PLC gamma 2 mutations cause mast cells to degranulate in the cold and in the skin. And those patients will often have an elevation in mature tryptase because their mast cells are just degranulating in the cold all the time. And then your basal serum tryptase, ignoring whether it's mature or the protryptase, which is the alpha and beta tryptases, which are released constitutively. This is your basal serum tryptase. This can be elevated again in mastocytosis and also in kidney disease, and at least until now, and the elevations until a number of years ago, kidney disease, another myeloid issue besides mastocytosis, would lead to an elevated serum tryptase, but I'll show you later. Actually, there is a genetic explanation in about 5% of the cases. But nonetheless, what's down here are these monomers, which are not thought to really impact anything. And what's up here is the tetramers, which are released with mast cell activation. The assay that we do does not distinguish, that is commercially done by Mayo Clinic and by just about anybody on a CLIA basis, combines both mature and protryptases to see what your tryptase is, whether at baseline or when you have a reaction or a symptom that appears to be mast cell mediated. Okay. So what about other lab markers? For some period of time, PGD2 in the blood was something that could be helpful, but it really doesn't appear to be specific enough for prime time, as they say. Urinary metabolites do seem to be a relatively specific marker, usually, especially when 3 different urinary metabolites are done at the same time, of different of prostaglandins, leukotrienes, and histamine. Those metabolites that I've listed here can be sent off. They're not as easy, especially since the most accurate way to do it is as a 24-hour urine, but it does give you more of a time frame. So that tryptase elevation is only going to be elevated for about 3 or 4 hours, and it's in that 3 or 4 hour period of being symptomatic. The patients are often need to demonstrate or want to demonstrate that it is mast cells that are the mediators of their symptoms, and they want to show that the tryptase has been elevated, but very often it's just not caught in that time frame, and the urinary metabolites give you a bit more of time in that regard. And it's also something that the patient can just have is to have a cup for the urine sample, so that they don't have to sit and beg and plead for the tryptase to be drawn in their blood. They actually can then collect the urine after an episode, provided the order has already been placed by the physician, and then return it properly, kept refrigerated and the such. But it still makes it more likely that it'll catch the event that has happened. But of course, these mediators are only useful when compared to the patient's baseline. And so either get the baseline done when they're in your office, and then have them put in place another order, so that when they go out and have one of these episodes and become symptomatic, they can have the urine sent. That's a more practical way to do it. It's not done as much, and it should be. That's really the easiest way to get this done. There have been plenty of other mediators that people will send off, but really none of them are validated, and an elevation or a lack of an elevation doesn't really tell you much about whether the patient has a mast cell related disorder. Okay. In terms of managing mast cell activation syndromes, I'm not going to belabor this point too much, because we can talk about the symptoms, the attributed mediators, and the therapeutic interventions which would be targeted to those mediators and those symptoms. But let it be made clear that outside of mastocytosis, there's never been a placebo-controlled trial, randomized placebo-controlled trial, as I will mention again later on, in the treatment of mast cell activation syndrome, period, end of story. There have been trials for patients with urticaria, but not necessarily in the context of an idiopathic mast cell activation syndrome, which is kind of an important point to make. So really, in the end, all we are doing is empiric therapy with all of the same tricks that we have. My general path for someone who has just constant symptoms which involve multiple organ systems, and symptoms that happen frequently is first to get on high dose of H1H2 blockade. And then second, if that helps some but doesn't really work all the way, would then be to move to either cromolyn when the GI symptoms are significant. And I should say that the GI symptoms, usually abdominal cramping, diarrhea, and vomiting, those are the main symptoms that are seen in mastocytosis and are then extrapolated to mast cell activation syndrome to be what is an abdominal symptom that is due to mast cell mediators. But I think that nausea and dysmotility and pain, although not necessarily the awful attacking pain that one can see, those can be seen in the context of mast cell degranulation. And so perhaps one has a wider, more open mind as to what could be a GI symptom attributed to mast cell activation, for which oral cromolyn sodium would be an ideal drug. And so again, if H1H2 blockade does not fully satisfy it, and if it would seem that the GI symptoms are worse, oral cromolyn sodium really can be effective, at least anecdotally. Again, I have no, unfortunately, there are no randomized studies to validate it. But it appears to be that people with abdominal symptoms really can get better. It's just that the oral cromolyn sodium has got to be introduced slowly. If you go straight to 200 QID, you'll probably cause abdominal pain more and they won't tolerate it. We usually start it at 100 milligrams once a day, and then over 8 weeks get up to 200 QID, and only then decide whether it's effective in controlling the abdominal symptoms. Ketotifen is then the other second line thing I will try. It has to be compounded in the US, but it is available. You can prescribe it. Sometimes people will get it from Canada or Europe or somewhere else. But ketotifen for more systemic issues, not in the gut, cromolyn when it is in the gut are the second line. And then depending, we can discuss whether omalizumab is worth it, whether Singulair is so hit or miss that I usually, it's just not part of my particular algorithm, but others seem to get some success from it. As long as it's in your armamentarium, it's something to try. But I should say with any of these things, the most important thing is usually what I would say is if it's going to work, it's going to work in a week or two. You'll notice it, keep a symptom diary. If you don't see it, then don't keep doing it because you're not going to get much more than that. With the exception of omalizumab for things like urticaria, we should wait a couple of months. And as I mentioned, with the cromolyn, you have to wait to get to the maximum dose. But then once you're at the maximum dose, it should be working relatively soon, if it's going to be working. Okay. Well, what else could it be? I mean, why shouldn't I try every mast cell mediator blockade in the world for the patient who comes in? The truth is there can be any number of different entities which have some overlap. I've highlighted a number of them here where, in the real world, you really could confuse what they've got with what's going on. I think one of the most striking things is dysautonomia. So anaphylaxis can often be misdiagnosed when it really is an autonomic or dysautonomic complaint that can impact the belly in terms of motility. It can impact sweating and diaphoresis that a patient might have. It certainly obviously can affect blood pressure. Very often the patients, though, will come in saying that they're anaphylaxis and either be tachycardic and hypertensive, which is so atypical for anaphylaxis and so common for the way that these patients will present that it's probably not anaphylaxis, or they will have hypotension, but it'll be in the context of bradycardia, which is usually vasovagal syncope, or you will see lability of tachycardia, bradycardia, hypotension, and hypertension, which again is much more likely to be an autonomic problem than it is to be a mast cell activation issue. So that's one major area where I will often refer my patients, especially with symptoms that just don't seem to fit the bill super well. I will refer them for an autonomic workup. The question then, of course, to the autonomic doc is this something real? Is it really a small fiber neuropathy that may be affecting the autonomic nervous system, or a small fiber abnormalities by biopsy? Are they really going to be contributing to the symptoms this patient has? I think that's an area where research really needs to pick up more, but I think you will find patients who have pathologic small fiber neuropathies and these symptoms. And so working both with the neurologist and with the allergist to sort of get at it is going to be an important thing to do, even before one makes it to the mast cell specialist. There certainly can be other gastrointestinal motility disorders. There can be a number of endocrine issues. I think pheochromocytoma is usually the concern, or carcinoid, because it really can look a lot like mast cell activation syndrome, and it can be missed. And so very often catecholamines, I'll send that when I'm a little bit suspicious in an adult. Making sure that the urticaria isn't vasculitic and that it isn't more of a systemic inflammatory disorder that is not mast cell mediated, or at least not centrally mast cell mediated. Often the urticaria that patients can come in with doesn't seem to fit, and they'll talk about it lasting for a while, and they'll talk about leaving a bruise and think that that's because they have severe mast cell disorder, when really it may be urticarial vasculitis. And then always, just making sure that H. pylori is not driving an urticaria in some cases, which can also then contribute to belly issues and create a picture of a mast cell activation syndrome that isn't just a specific entity that we already know a little bit more about. Okay, and again, this is not an exhaustive list. It's just to say that it isn't just that you're crazy, and I put somatoform disorders in there. There could be other things that ought to be excluded, although often these patients will come in having seen 12 different doctors because the answer was either to blow them off, or they didn't get an answer that they were looking for. We've absolutely positively had a number of somatoform disorders in children admitted on the pediatric side, with some terribly unfortunate outcomes in some cases. But I think those cases end up throwing the baby out with the bathwater. There are folks who are out there who truly do have mast cell activation disorders of all sorts, whether idiopathic or not. And it's important to have a very efficient way of getting through. And then afterwards, you can decide that, the workup is done here and what I can do is done here. Now, with respect to MCAS and mastocytosis, again, when you think about mastocytosis, this is really now focusing on, this is a review focusing on mastocytosis. We sort of have the pre-diagnostic systemic mastocytosis or indolent systemic mastocytosis, where you have more, actually in many cases, more mast cell mediator and skin symptoms that are present, which can include neurologic symptoms, I would point out, like cognitive difficulties, depression, headache, and sleep disturbances. Then when you have more of a smoldering or an aggressive systemic mastocytosis, that's when anaphylaxis comes out. That's when bone issues of mastocytosis come out, such as osteopenia or porosis. And then more constitutional symptoms like fatigue and arthralgias can come in, as would happen with a myeloid disorder of all sorts. And then finally, in the minority of cases, moving to a mast cell leukemia is where you can get lymphadenopathy, splenomegaly, and cytopenias. That's what you, of course, worry about the most when you have a systemic mastocytosis patient from an acute medical issue. But of course, more common morbidity is the anaphylaxis, the bone issues, the constitutional issues, neurologic complaints as well. So that's where the organomegaly or organopathy becomes more prominent, and the disease burden and aggressiveness becomes more. Again, at the very far end on the right is mast cell leukemia, and on the far left is pre-diagnostic systemic mastocytosis, which sometimes only comes out after, let's say, a bee sting and then a bee anaphylaxis, and there were no other systemic symptoms that the patient had. But just so when we talk about indolent symptoms, which can lead to that which is on the left, versus aggressive symptoms, which is in the middle, and then the rare cases where you get a leukemia on the far right. Now, when it comes to, so let's go through some organ systems. So irritable bowel syndrome, or complaints that overlap with irritable bowel syndrome, is one of the main complaints that patients will come to a doctor and say, I think I have a mast cell disorder because I have this terribly bad belly. And again, attacks of cramping, awful abdominal pain with diarrhea and vomiting, that is the most classically associated with a mast cell degranulation, like food allergy, or with a more aggressive mastocytosis, or in some cases, indolent systemic mastocytosis. That's where you can see it. But it's interesting that in looking at large, in a large cohort that was done in this particular study across the health system, you had an odds ratio of, if you had a mast cell disorder of urticaria, to have IBS, if you had urticaria already, you had a 4-fold increase in your chances of having IBS. If you had a mast cell disorder, a mast cell malignancy or a mast cell disorder, there was a 7 to 10 fold increase in having IBS, and then having the diagnosis of mast cell activation syndrome, which again, it's not differentiating whether it's due to a clonal mast cell disorder or if it's idiopathic or the such. That was a 16-fold increase. I don't think we should pick apart exactly what the numbers are, but just to say that the presence of idiopathic urticaria or urticaria for other reason is enough to increase the chances that IBS will be found. And to me, that is certainly an indicator that whatever the process is that's driving that urticaria may well be driving IBS. And is that like urticaria of the bowel? It could be, whether or not a clonal mast cell disorder is present. And so I think that is an important thing to keep in mind. What about the dysautonomic issues, the postural orthostatic tachycardia syndrome, fainting, the palpitations, what seems sometimes like panic attacks, the lightheadedness? The question is whether the fatigue can be attributed to this autonomic dysfunction. Well, again, in that case, there are a number of mediators that may differentiate POTS alone from POTS with other atypical symptoms that may then contribute possibly to the chance that mast cells are contributing to this POTS-like issue, such as prostaglandins or histamines or tryptase. But this study, which was quite interesting, so on the left is the mediators that you may find in a small number of folks who have POTS with atypical symptoms and abnormal testing versus POTS alone. But what's interesting is when you go back to the symptoms themselves of syncope and of fatigue, of lightheadedness, migraines, and the such, you actually really don't get much of a significant difference if you have in those patients, you have abnormal testing versus not. And so, is this a misdiagnosis of POTS or a misdiagnosis of mast cell activation syndrome? It's hard to say, but it is, and this is obviously a very small N, but at least in this particular case, the gastrointestinal symptoms did seem to show up more with abnormal laboratory testing versus than with normal laboratory testing. The POTS piece is a different question. Depression, and I think this is a very important thing that's just not picked up enough. Depression is incredibly enriched in people who have mast cell activation syndrome. So again, we can debate whether the criteria for mast cell activation syndrome are met perfectly in every one of these studies, but what's not debatable is that a huge number of patients with a label of mast cell activation syndrome can be depressed compared to those who are not depressed. Stigma, loneliness, disease-specific stressors, and illness intrusiveness are contributors to the chances that they will end up being depressed. And then there are things like optimism, self-efficacy, social support, which are actually protective against developing depression, which are important things to know about. And it's always a chicken or egg question. Is the depression or anxiety promoting these symptoms, or are these symptoms promoting the depression anxiety, or is it a vicious cycle? And I think the answer is probably pieces of all of those. I think the answer, and I don't think we can ever really be sure that it's just one, that they're just crazy, or to put it bluntly, which is what many of my colleagues say, versus it all being mast cells. And what I tell the patients is anybody who tells you it's all in your head is a jerk, and anybody who tells you it's not at all in your head has no idea what they're talking about, because there's obviously a major interaction of mast cell mediators and central nervous function and such. Okay. I would point out that PAR2, which is a receptor for tryptase, one of the key markers of mast cell degranulation, PAR2 activation is necessary for something called sickness behavior in mice. So if you give mice an infection, they have sickness behavior, which is an evolutionarily conserved thing to sort of shut things down, not eat as much, not be as active, and not be as social. And if you knock out PAR2, then the mouse goes and has a party as though nothing's going on when they are injected with, let's say, LPS, which is mimicking a bacterial infection. The question is the flip side. Could tryptase, elevated tryptase, chronically elevated tryptase from mast cell degranulation provoke sickness behavior that might explain many of the cognitive symptoms that can come up in mast cell, clonal mast cell disorders, as well as some of the mast cell activation syndrome disorders. Okay. I would note that sucrose preference is the lack of sucrose preference. It's a sickness behavior, which is interesting. Okay. Okay. So what about interventions for mast cell activation syndrome? There have been a number of studies on this. So I guess what I like about this particular study is that a couple of patients had more of a idiopathic mast cell activation syndrome. Some of them had confirmed mastocytosis, and then therefore a mast cell activation syndrome secondary to mastocytosis, which is primary mast cell activation syndrome. The bottom line was that there were in a number of these patients, there was substantial control of their disease with omalizumab. There have been, which I think is an important point, is that in mastocytosis, or in MCAS, whether due to mastocytosis or idiopathic mastocytosis, and some of these severe patients, you can get relief of symptoms. There's only been one randomized trial, and unfortunately, in mastocytosis itself as a cause of mast cell activation syndrome, it did not reach significance for any outcomes, but perhaps the N was not big enough to really be sure about it. Again, with respect to treating mastocytosis, again, this is again from a review that came out actually last year before avapritinib was approved for aggressive systemic mastocytosis. But nonetheless, it certainly one could use omalizumab and the other H1H2 blockade or mast cell stabilizing agents in indolent and smoldering systemic mastocytosis. And I do encourage reading this particular review. It's very nice. You have a slide, so you can pull it up yourself. It's really when you get to aggressive systemic mastocytosis that you start to do something besides going after the symptoms, which we would do. There are many different ways that we might. And that's where avapritinib could be a choice, midostaurin can be a choice, imatinib in some cases, interferon alpha in some cases, and in really significant refractory or relapsed and proven aggressive systemic mastocytosis, a bone marrow transplant could be considered. And of course, if you have systemic mastocytosis and a neoplasm, that is a whole nother ball of wax that almost always involves hematology. But I would focus on the far left here, which is really where the majority of patients would come in to see you. And there again, we're doing symptomatic treatment of mast cells. But again, if it is systemic mastocytosis, then there also need to be considerations for perioperative management and considerations for osteoporosis, like bisphosphonates and such. But I think at that point in time, usually the patient is in the care of a mastocytosis center, at least for an annual check-in and that sort of thing. A note on pediatric mastocytosis, it almost always involves the skin. I think this is, I guess, the best clinical pearl I could give, which is that you will almost never see a case of pediatric mastocytosis in the absence of urticaria pigmentosa or in the absence of a mastocytoma. It simply doesn't happen. I think where it gets tricky in pediatric mastocytosis is that the UP or the rash that they get can be very polymorphic. It's not like in adults where you sort of have a good sense of what UP tends to look like. Mastocytomas and or the cutaneous manifestation of mastocytosis in a child is far more polymorphic. When those cutaneous symptoms are found, The age is when the child is less than 2, that's actually a good prognostic indicator that they will be growing out of it, that they're not likely to proceed to something more aggressive. But regardless, in general, if you have UP in a child or mastocytoma, it really tends to be just limited to the skin. Rarely does it become progressive to something more aggressive, and rarely does it progress into adulthood one way or the other, but it can be years. Those patients are, though, always in an increased relative risk for systemic allergic reactions, and so therefore they do need to be managed differently than the general population when it comes to perioperative considerations. Up to 8% can actually have a systemic reaction to a vaccine in childhood, but that does not, usually they're not severe, and so we do not usually advise to do anything different unless if they have a systemic reaction, then they should have it broken out into components to figure out which reaction it was, which vaccine it was that they reacted to. Okay. Again, this slide is a very important slide. Let's go back to the mast cell activation syndrome. Without mastocytosis as a cause, there are no randomized placebo-controlled trials. We're doing this entirely by anecdote and case series that are heavily biased to ascertainment bias, to lack of placebo bias, to diagnosis bias, and until then, it really is just you pick your particular algorithm for what you're going to do, and that's what folks tend to go with. Okay. Now, I do want to add, in the context of this, a couple of words about histamine intolerance, because more and more patients are coming in with symptoms that look like mast cell degranulation symptoms, usually in the gut, but sometimes outside of the gut, which makes it all the more difficult to understand how histamine can be a mediator, since normally histamine is degraded very, very quickly in the plasma, and it makes it hard to have a systemic or even another organ besides the gut be impacted by histamine in the overwhelming majority of patients. But there does exist the concept of histamine intolerance. And there are two main ways that this can happen. One would be secondary reasons, such as taking a medication which interferes with thiamine oxidase, which is what used to be called histaminase, which breaks down histamine, or where you've provided too much histamine, right? So in an anaphylactic case, you've overwhelmed the thiamine oxidase, the normal amount of thiamine oxidase, and then you get, they're calling it here on the left-hand side, histamine intoxication, but really what it is, again, this is a nice review just to sort of lay out the issues. You've just provided too much histamine and then got a systemic reaction, but those are the, that's how it could be, where you have normal thiamine oxidase and you still would have a systemic reaction, would be too much histamine, or again, where a drug that's inhibited thiamine oxidase activity, and the list is long, and I would it's just something to think about for reference. And then there are those who actually do have a primary thiamine oxidase deficit for whatever reason. It's a little bit like being lactose intolerant, where you just don't have enough lactase, you don't have enough thiamine oxidase, usually in the gut, and then that allows for more histamine to be present in the gut, and potentially more histamine to then make it systemically. And so the things to do about it are to try a low histamine diet. It's been my experience that lots and lots of folks who are worried about mast cell activation syndrome do not respond at all to a low histamine diet. But I have patients who've come to me and said, a low histamine diet helps me a lot. And I say, you know what, I actually don't think this has much to do with your mast cells at all. It's just that you can't process histamine, right? And now, of course, if they have mast cell degranulation and they can't process the histamine that mast cell has made, they may have an amplified response to it, in which case then mediator blockade could be helpful. Although not leukotriene and prostaglandin blockade, really it's just blocking the histamine or blocking that mast cell from degranulating. There have been controlled studies with low histamine diets. They're not, and there have been some positive results, although I think larger studies are really needed to really show in whom it really works. And there have been randomized controlled, placebo-controlled studies showing the thiamine oxidase supplementation, like giving lactate right before eating. Instead, you would give this histaminase right before eating can be helpful for these symptoms in certain patients. But larger studies and better diagnostic criteria need to be applied to really know. But I think it is important that this is not just a diet fad that's out there. There may be people for whom this is relevant, and this is sort of the framework through which to consider it. Okay, another very important patient population who will come in, and that is those who have the interesting mix of a connective tissue issue and a somatic mast cell disease. Okay, so we know that mastocytosis can be associated with itching, flushing, anaphylaxis, and terrible abdominal pain and such. But then we also have patients who have a of joint hypermobility, scoliosis, maybe some pectus, who then have a list of symptoms, many of which are functional, that overlap with that which you can see in mast cell degranulation disorders like dysautonomia and POTS, abdominal pain and or IBS or dysmotility, chronic pain of all sorts, cognitive disruptions like brain fog, easy bruising and bleeding, which can be seen in both cases, anxiety and depression, behavioral issues, which absolutely can happen in both, as I mentioned, in mastocytosis, and you can see them in lots of reviews of joint hypermobility syndromes, and asthenia, sort of a depressive state or a fatigue state, can be seen in both of these cases. And so what that then leads to is patients who say, I've got this syndromic problem of joint hypermobility, or I now have a label that I've met the clinical criteria of Ehlers-Danlos syndrome type 3 hypermobility type, and I have these symptoms, I must have a more complicated multi-system syndrome that includes mast cells and connective tissue. Again, you'll find in the literature overlap of this middle thing with EDS and overlap of the middle symptoms, of course, with in our world with mastocytosis. And the question is this an independent entity? And the answer is we're really not so sure. There's a huge ascertainment and referral bias amongst those with joint hypermobility, which may not be nearly as rare as we think it is, and with mastocytosis. And I would point out that indeed, it's been unfortunately very, very low yield to look for genetic explanations for Ehlers-Danlos syndrome type 3 hypermobility type. A very small fraction may have mutations in a gene called TNXB. Perhaps 1 in 200 patients with hypermobility will have those variants. The rest is to be, there isn't really a way to know. It's just a clinical diagnosis. And there are certain things which overlap. And it's unclear that mast cells themselves then are contributing to the issues that happen in patients with Ehlers-Danlos type 3. Doesn't mean they're not. It's just that we do not have a well-validated study that would show it. This is just a review from some colleagues that just simply pointed out that we don't know pathophysiology of POTS, and an evidence-based common pathophysiologic mechanism between even two of these, either EDS, POTS, or mast cell activation syndrome, hasn't really been shown. And really, we don't have a well-validated study that actually shows there's a relationship between all three that is not due to referral biases and ascertainment biases and misdiagnoses. And so it's not to say it's not there. It's just that right now we do not have very decent evidence. But when you see it, it is florid. They are absolutely hypermobile. They have symptoms all the time. They have flushing. They can get urticaria. They have objective symptoms. And the question is just, is this just what it looks like when these two or three entities happen to the same person? Or is there a single driver for all three? And the question is, we're not sure. And I'll come back to that in a little bit. Some other interesting points to bring out is that it appears that having an increased serum tryptase, which is again one of the markers, certainly appears to be enriched for those who then amongst those who have systemic reactions to Hymenoptera venom. And so you can have, as your presenting symptom of mastocytosis, a bee sting. In the US, it appears it's not as common, and I think in many ways this is strictly due to the referral biases and patterns of bee sting anaphylaxis and of mastocytosis in the US versus in Europe. And it also may vary, it actually may differ with the type of Hymenoptera that are more prevalent in the particular, where the particular center is. But I should make clear that the work of Patrizia Bonadonna and Roberta Zanatti is in a referral center in Italy. And in the US, almost all of the bee venom studies are done in referral centers. And so you get a referral bias. So it's a little bit hard to say, but it still is the case that it is quite possible that occult systemic mastocytosis will occur in a patient with bee venom anaphylaxis. And the elevated basal serum tryptase could be what tips you off to the fact that they have that when they're being worked up for their bee venom anaphylaxis. We actually have a collaborator in Slovenia where there is no referral bias. There's only one place where all of the Hymenoptera allergies go, and that's in Slovenia, where actually I think beekeeping is actually an industry. So the overwhelming majority of these data come from bee venom hyperresponsiveness. And without a referral bias, one does see quite an enrichment amongst the most severe grade 4 Hymenoptera venom allergies. You'll see an enrichment for D816V positive in the blood, substantial, significant enrichment, and also an enrichment for something called hereditary alpha tryptasemia, which I'll get to in the end, that then account for all of the basal serum tryptase elevations in people who have bee sting, severe bee sting anaphylaxis. And I think that's important because really then we know what's the cause. It's either going to be mastocytosis or hereditary alpha tryptasemia. When you see that elevated basal tryptase, when you're working up a patient who had bee sting anaphylaxis, to me, it's enough to say that that basal tryptase should always be drawn, even though it sounds like it's a textbook case of Hymenoptera of anaphylaxis. Get that basal tryptase on follow-up, because you may find an occult systemic mastocytosis that way, number one. And number two, you also may find hereditary alpha tryptasemia, again, which we'll get into in just a moment. So let's talk about hereditary alpha tryptasemia. So we know that in population studies, that about the normal serum tryptase has been drawn as 11.3. That was a statistical drawing. It was just to say what makes a high tryptase. We made a cutoff of 11.3 as normal, and anything above that was high. But in the end, at least in the Caucasian population, 4 to 5% of that population have a high basal serum tryptase. And under no circumstances do all of those people, healthy donors, have mastocytosis. So what's going on with that elevated serum tryptase? There's been one study in a single private practice in Austria, I think, where they looked at an allergy practice, people who had high serum tryptases versus low serum tryptases, where they didn't know that when they were walking in. There was an incredible enrichment for lots of symptoms that we see in mast cell activation syndromes or in mastocytosis, like flushing and angioedema and IBS and diarrhea, abdominal pain, and dysautonomia and fatigue and the such. And many of them were statistically significant higher in those who had a high basal serum tryptase versus low, suggesting either active mast cell activity or that just there's something about that basal rate that puts them at risk for those symptoms. We then had described that the elevated basal serum tryptase in about 5% of the Caucasian population is overwhelmingly explained by a genetic event, a dominantly inherited genetic event of a duplication of alpha tryptase at the locus TPS-AB1, which can encode either alpha or beta tryptase. So instead of having just one, either alpha or beta tryptase on the one allele, they have duplicated alpha or triplicated alpha, or we have patients with 9 copies of alpha on one allele. And there's a linear association of your basal serum tryptase with the number of alpha copies in these cases. 5% have duplications, much lower numbers have triplications or more in the population. Those duplications of alpha tryptase that are genetically inherited in Caucasians explain the overwhelming majority of the elevations in serum tryptase at baseline. When we first reported this, it looked to us like this was a rare disease that had systemic, cutaneous, and neurologic, psychiatric, autonomic connective tissue complaints associated with mast cell degranulation, not associated with mast cell degranulation. There have been some further studies showing unique bone marrow findings, small intestine pathology findings, but there's a massive referral and ascertainment bias that we need to be able to go into an untouched population of volunteers who've sent in their blood so that we can see what their basal serum tryptase level is, who have a genotype to see if they have hereditary alpha tryptasemia, and then who have put their symptoms down without knowing whether or not they have elevated serum tryptase. That's what we need. Only small studies like that have done. We did it in a population of about 200 people, which is where we thought that we saw an enhancement of IBS and of in a volunteer, healthy volunteer population, an enhancement of IBS and an enhancement of bee venom allergy is what we thought that we saw in a small group, but it's so small that those may not have really been the real thing. We think that having those extra copies of alpha may actually predispose you to have a mast cell degranulate more. We saw vibratory urticaria in people who carried up duplications much more in those who did not. And actually PAR2, again, that receptor for tryptase, can lead to vascular permeability and leak when alpha beta tetramers get released, and as opposed to just beta. So it could be that having more copies of alpha increases your risk for vascular permeability and for vibratory urticaria and the such. But again, the independent disease associations require systematically going one by one. I'll give you some examples. Again, this is the vibratory urticaria on the bottom right, putting someone's arm on a vortex and then looking at the itching, the erythema, and even in some cases, actual hives that form soon afterwards. It's not as uncommon as we think. So I'm going to skip over this piece and also just point out that actually the elevation in serum tryptase, you have to have more than just 20% plus 2 if you have hereditary alpha tryptasemia, or if you have an elevated basal serum tryptase due to mastocytosis. It's more like 70% of the baseline is what you need to really tell you that there's been a systemic mast cell degranulation event. So that 20% plus 2 doesn't even apply if you have mastocytosis or hereditary alpha tryptasemia, which is an important clinical point. The symptoms that have been reported in hereditary alpha tryptasemia, you see anaphylaxis, gastrointestinal, cutaneous, all these symptoms in huge percentages of the patients. But that doesn't tell you, if you took patients just with the 5% of the general population who have hereditary tryptasemia, that this is what it would look like. And that's really a very important clinical point. I cannot tell you, except with some few exceptions that I'll show in a few slides here, what symptoms truly can be attributed to hereditary alpha tryptasemia, besides an elevated serum tryptase and a couple other things. In fact, Jem Aiken looked, again, in a very, very small sample of just 34 patients from a non-selected, from a completely unbiased population. He didn't see differences in symptoms between those who had HATs versus those who didn't, but unfortunately, he's not powered to see differences with numbers that small any more than we were powered in the small study that we did at the NIH, where we saw some differences. But just to point out that in a biobank study, just about everyone with a tryptase above 8 had TPS-AB1 duplication, whereas in the normal population, very, very, very few did, with one exception who may have been may have not known it, but may have had mastocytosis. This test to look for the elevation in the tryptase duplications causing hereditary alpha tryptasemia is a digital droplet PCR test. It's really only performed right now clinically by a company called Gene by Gene, and then on research bases, there are folks who could do it throughout the country and in the world. But it is a useful test, and I think it's important, and I'll describe it in just a moment. I will say again, in a referral biased population who have symptoms and hereditary alpha tryptasemia, omalizumab can be very helpful. What omalizumab does not help very much with is the symptoms of autonomic dysfunction, palpitations, diarrhea, and joint hypermobility, which we don't necessarily think are related to mast cell degranulation to begin with. But yes, if they have those symptoms in hereditary alpha tryptasemia of mast cell degranulation, omalizumab may be very helpful for those patients, and we did see that. And others did as well. What if we just took a huge cohort of patients with IBS and did the digital droplet PCR to look for alpha tryptasemia? We actually see in Caucasians, it's the same 5% as the general background. So in no way does hereditary alpha tryptasemia contribute to the risk for straight biopsy-proven functional irritable bowel syndrome. However, if you take patients with hereditary alpha tryptasemia and look at their gut biopsies, even though their symptoms look just like IBS, you will actually find a massive increase in mast cells, Fc epsilon R1 positive mast cells, and in a particular tissue a change called pyroptosis, which requires special stains, that's increased on the level that one might see in Crohn's disease in hereditary alpha tryptasemia. So they may not meet the criteria for IBS, possibly because it's a different entity than IBS. Where we do see is if we took all patients with idiopathic anaphylaxis, almost 20% of them had hereditary alpha tryptasemia. That is likely telling us that hereditary alpha tryptasemia can contribute to the risk for idiopathic anaphylaxis. 15 to 20% of patients with systemic mastocytosis, we've shown it in Europe, they've seen it in several different cohorts. 15 to 20% of patients with systemic mastocytosis have hereditary alpha tryptasemia. So we do think it puts you at risk for developing mastocytosis, although the absolute risk is still only double or triple the general risk. So as rare as mastocytosis it is, doubling or tripling the risk is still rare. However, those who have mastocytosis and have, and of those 20% of them who have hereditary alpha tryptasemia, they actually have a worse, much more severe venom anaphylaxis. And in fact, again, back in Slovenia, the most severe cases were enriched for hereditary alpha tryptasemia and mastocytosis. And oops, I don't have it here, but I would also just say that the severe symptoms within mastocytosis, like anaphylaxis, were much more present in those who also had hereditary alpha tryptasemia. So it's modifying the disease. It modifies your risk. You already have bee venom allergy. It will make your risk for severe bee venom allergy worse if you have tryptasemia, and it will make your mastocytosis more severe as well. And I think that we will end up having some changes to the mastocytosis diagnostic criteria based on whether or not you carry the allele for hereditary alpha tryptasemia. Practically speaking, one of the most important things I can tell you about hereditary alpha tryptasemia is if you have an elevated serum tryptase symptoms and you don't have the duplication causing hereditary alpha tryptasemia, you likely have a pathologic cause for your elevated basal serum tryptase. I think that's a really important point. And so we've have multiple patients who come in, referred to us. Is it tryptasemia? Oh yeah, it must be. Their tryptase is high, they've got classic symptoms. They end up not having tryptasemia, perform a bone marrow biopsy and find abnormalities in the bone marrow or systemic mastocytosis. So even though yes, having tryptasemia, to a small extent increases your risk for developing mastocytosis, in any patient who comes in with a high tryptase, the absence of carrying the alpha tryptasemia allele actually makes it more likely that that's the patient who has got mastocytosis. Even though their tryptase is only 15, they may be the one who needs to be biopsied. On the question of joint hypermobility, which we totally saw in all those patients who thought they had a multisystem disease all the time, you will not see more hereditary alpha tryptasemia in those patients. 5% of patients with joint hypermobility, 5% in the general population, it's not enriched. However, if you already have joint hypermobility, and then of those folks who have hereditary alpha tryptasemia, you are more likely to have retained primary teeth, and you are more likely to have dysphagia, swallowing difficulties. So again, that may be an illustration of how it can modify disease and underlying disease if you carry hereditary alpha tryptasemia, since it's such a common allele. I would point out that in the case of both urticaria and EOE, if you have a higher baseline tryptase, you're more likely to have comorbidities in addition to urticaria or EOE, such as asthma, arthralgia. In the case of EOE, you have comorbid urticaria, sinusitis, and nausea and vomiting are all higher in patients with EOE who have elevated serum tryptase. And it suggests that that's, again, quite likely hereditary alpha tryptasemia modifying the disease. It also may point to increased mast cell activity driving the high tryptase. But as I said, a tryptase higher than 11.4, overwhelmingly, it's explained for in the general population by hereditary alpha tryptasemia. Okay, and I would also point out that persistent elevations in serum tryptase are seen in patients with severe COVID and in long COVID. And I would watch that space to see that if there is indeed hereditary alpha tryptasemia contributes to risk for severe COVID or for long COVID. I want to end there so that there's some time for questions. And thank you so much for your attention. And also to point out that the word of the day is ivy. There we go. And if anyone is asking a question, you're muted at the moment.
You hear me now?
Yes.
Yeah, thank you very much for that presentation. A lot to unpack there. I think we may have to have you back next year to go over some of that again, hopefully in person. Simplistic question about dietary histamine. Since it's so rapidly degraded, I've never really understood things like scromboid poisoning and the value of a low histamine diet. Is that valuable just in the small percentage of people who may have poor metabolism of histamine?
Yeah. Well, I mean, I think that's really where the question really lies, right? We need bigger studies where we actually measure, are they diamine oxidase insufficient, right? And then amongst them, are they the ones who then respond to a low histamine diet? And that is, if you look at some of the trials, that is, they really did try to look and see. They would take people who truly were diamine, and there are a number of ways of assessing diamine oxidase insufficiency and or giving a histamine load and then actually just looking for the persistence of histamine or histamine metabolites in the blood. It's being done. I think, you know, again, like everything else, you want to try the low histamine diet for a week, and if it works for you, gesund, great, fantastic, right? But it does appear that there are folks who truly do have increased symptoms because they have low diamine oxidase activity, who then respond to a low histamine diet and are and or respond to being given exogenous diamine oxidase. So I think it exists. I just don't think we have a great handle on who that person is and how powerful of an effect it is to go on that low histamine diet, because you know, I've seen it so many times where it doesn't do anything, that as I suspect a lot of our colleagues are, but those folks really are out there, and it may not be such a small percentage of the population.
Thank you. Other questions from our audience? In one of your early slides, you showed the tetramers of tryptase in the secondary granule, and then it appeared that more conventional tryptase was in a different granule. Was that intentional? Is that true?
Yeah. So I'll just show it again super fast, because it's not only a point of how the basic biology works, but it's also what we're measuring. So these monomers that get made initially get packed up into a tetramer for degranulation, you know, and pretty much only for degranulation. But these secretory vesicles here are constitutively released from a different type of vesicle and not triggered by FcεR1 all the time. So yes, whether these monomers have any biologic activity, we really don't know, but they are absolutely released. And again, if you have alpha tryptasemia, more of them are released. More of these alpha monomers are released constitutively all the time. We don't know a lot about how that impacts the tissue. Like I said, in the heterotetramer form, when it is degranulated, it does have more activity than when it is in the alpha tryptase. Alpha beta heterotetramers have more activity, but that basal serum tryptase is actually these monomers being released and leaked out constitutively in almost every person in the world.
Other questions from our audience?
Hi, this is Vinod Doris, one of the practicing allergists. Thank you for a really wonderful talk, and thank you for taking my question. I just want to clarify at least a comment, when you talk about IBS and urticaria of the bowel, are you saying, in a small, meaning if so, is it a small number of IBS patients that there may be a mast cell activation, majority or not? Or is there a connection between, again, a lot of the patients that we see with chronic urticaria, which most of the time we don't think is mast cell activation by itself, even though they do respond to high dose antihistamines, and they may also have concurrent GI issues.
Yep.
Can you clarify the connection that you're trying to make there? Thank you so much.
Yeah, so absolutely. So first of all, I would differ and say that urticaria absolutely is mast cell activation, but it's exactly to my point where we're not saying the patient has mast cell activation syndrome. We're just saying they have mast cell activation, and that's what's causing their urticaria, right? And therefore, mast cell mediator blockade will help with it. And in some people you have to go on to give, omalizumab, and that sort of a thing in most cases. So it is mast cell activation that's causing it, and they may well just have a predisposition to mast cell activation in the gut that leads to IBS-like symptoms. There are plenty of studies showing histamine activity in the gut in patients with IBS, and mast cell degranulation in the gut in patients with IBS, and in randomized trials, mast cell mediator blockade or mast cell stabilization being effective for patients with IBS. Have they selected for those who have, let's say, concurrent urticaria? That would be nice, right? That would be a better population to say, yeah, those are the ones who are going to respond best to being more aggressive about mast cell blockade. Their IBS will respond better if they have concomitant chronic urticaria, but that is exactly who we're talking about. There'll be certain patients with IBS where it's not mast cell mediated, but there is absolutely a substantial percentage, but substantial could be, 10, 30, percentage of people with IBS for whom mast cells are responsible, at least in part, for their symptoms, and where proper mast cell mediated blockade may be quite helpful. It's been well described. In fact, IBS-like symptoms associated with psychological stress, actually was a clinical study done. If you gave cromolyn, you pre-treated, you actually prevented those symptoms and prevented leaky gut provoked by psychological stress when you give cromolyn beforehand. So in healthy volunteers. So that I don't think there's much question that mast cell mediator release can impact IBS. The question is, who are the patients who are going to respond best to aggressive mast cell mediator blockade or stabilization? I would not be saying that those are the patients who need to be worked up for mastocytosis or be getting, God forbid, Leveck or apritinib or anything like that. I'm just saying that there are patients who will be more responsive, their IBS could be more responsive to mast cell mediator blockade. Usually with multimodal, like there probably will also be a pain component and an amplified pain component as well that needs to be addressed even separately.
Anybody else?
Hi, Len. This is Paul McBride. I just wanted to ask, with the mediator measurements, if you have a duplicate measurement of your mediators, your 24-hour urine leukotriene-4 and Dynor and methylhistamine, and you see that they don't go up, can you tell these people they don't have this disease? Because that's the most difficult question we have to answer.
So what I would say is, first of all, again, if you see only one out of all of those, I would be concerned that you're just looking at something non-specific. Okay, that's why I like the pattern of all three. Number two is, the trick here is that is to draw them when they're totally symptomatic, right? And draw them when they're totally not symptomatic. And if you see no change, then you say, I don't think there's much worth in pursuing this any more than what already works for you. If your mast cell mediator blockade works for you, great. Is there anything else we're going to do, given the fact that we can't see a single mediator go up when you're symptomatic, even though your baseline is slightly elevated? No. I mean, does that answer it?
Yes, because these people often refuse to go away when you tell them they don't have what they think they have.
Again, they can have an elevated set of mediators. If they're asymptomatic when it's elevated, then there you go, right? For the ones, the trick is when they are never asymptomatic, right? And they're elevated. Well, okay, then I would play the game. H1, H2 blockade, does it help? Great. Give ketotifen, great. Omalizumab, great. Is there another tool that we really have? No. We're certainly not going to do anything with chemo or anything like that. So that's really the end of the road at that point in time. But we are treating them for mast cell mediated problems. They have an elevated mediator. It's always there when they're always symptomatic. It doesn't help. That's it. There is no other intervention that's helpful at this point in time without being on a research protocol, which I can promise you doesn't already exist. So.
And which anesthesia agents do you recommend for these people for when the anesthesiologists call us and say, what do you give these people?
Which people? So
the people who have sort of borderline questionable symptoms who have made all their doctors crazy.
Yeah, no, I would have them managed as anyone else, frankly. If they don't have, if they've anaphylaxed 5 times in the past, okay, that's legit. It may be a secondary MCAS problem, right? And therefore, they are predisposed to anaphylaxis, not necessarily because of a syndrome at all, right? Just it's secondary MCAS, right? And then those are people who should get that extra care. That's a clinical thing without any testing even needing to be done.
Okay.
And then what I often say is, do not be surprised if there are idiosyncratic things that happen. The whole steroid and histamine pretreatment thing, I don't know that there's any evidence that works for anybody for anything at all, but it makes people feel better. So we tell people to do it, but I'm totally skeptical that there's any evidence that does anything for any of our patients.
Perfect. Thank you.
Traditionally, we've always said there are 2 categories of mast cells. I forget the terminology now. Josh, are you still there?
Yeah.
And you've been using the term mast cell generically. Does it matter which category of mast cell? Remind me the term.
At no point in time was I using the term generically. So either I'm talking about idiopathic mast cell activation syndrome, or I'm talking about primary mast cell activation syndrome due to mastocytosis, or I'm talking about a secondary mast cell activation syndrome due to IgE degranulation.
No, I'm asking about, don't we histologically say we have 2 types of mast cells in humans?
Connective cell mast cells, mucosal mast cells.
Yeah, so no, for these diagnostic criteria, they're not different. That doesn't differ for the most part.
Oh, okay, all right. What are the names of them, Arthur?
Connective tissue mast cells and mucosal mast cells.
Right.
Yeah, okay.
So I think those are different for sure, and they may release different mediators to different triggers, but the clinical disorders that we're talking about do not differentiate between the 2.
All right, well, thank you. We've run over here, but we've retained half of our audience into the 8 o'clock or the 11 o'clock hour in Manhattan. Well, good to meet you. Thank you. I'll be reaching out to invite you to speak to us next year again. As I said, we take a break now until September. But it's nice to have met you. I've never met you in person. I look forward to that. Thanks again.
Absolutely, me too. Thanks so much. Take care.
All righty.